Obesity is no longer just a cardiovascular or metabolic concern. It is a rapidly escalating oncology crisis. The evidence is clear. Excess body fat is a direct contributor to cancer development, progression, and mortality. Yet despite overwhelming data linking obesity to at least 13 types of malignancies, weight management remains disturbingly absent from routine cancer care. This silence is not just an oversight, it is a serious threat to patient outcomes and a missed opportunity for prevention. For decades, obesity was treated as the domain of cardiologists, endocrinologists, and primary care physicians, relevant primarily in the context of diabetes, hypertension, and heart disease. But this compartmentalized approach is now dangerously outdated. Oncologists must step forward and recognize that managing obesity is not outside their scope. It is central to their mission. Ignoring it weakens the effectiveness of cancer care across the entire spectrum, from risk assessment and prevention to treatment response and survivorship. Obesity is now a recognized carcinogen. Its impact on cancer is not merely statistical, it is mechanistic. Obese individuals exhibit increased levels of insulin, IGF-1, estrogen, and pro-inflammatory cytokines, all of which promote tumor growth. Adipose tissue acts as an active endocrine organ, fueling cellular proliferation, DNA damage, immune evasion, and angiogenesis. The metabolic environment in obesity is hostile to therapeutic success and friendly to malignant transformation. This is not a peripheral issue. It is a foundational one. Despite this, oncologists are rarely trained to address weight during consultations, and many cancer centers offer little or no support for weight management. In many cases, even when the link between obesity and a patient's specific cancer type, e.g., breast, colorectal, endometrial, is well established, discussions about weight are avoided entirely. The reasons range from time constraints and discomfort with the topic to a perceived lack of expertise or resources. But the consequence is profound. Patients are often left without guidance, and their prognosis may suffer as a result. Research shows that obese patients are more likely to present with later-stage disease, often because early symptoms are masked or dismissed. They are also more likely to experience surgical complications, radiation toxicity, and altered pharmacokinetics that reduce chemotherapy efficacy. Moreover, some immunotherapies appear less effective in the context of obesity-driven inflammation and T-cell exhaustion. This is not speculation, it is clinical reality. Yet many oncologists still do not routinely adjust dosages, recommend weight interventions, or for patients to specialize nutrition or exercise programs. There is also an urgent need to integrate obesity screening into cancer prevention protocols. BMI, waist circumference, and metabolic markers should be treated as serious red flags in cancer risk assessment, alongside smoking history or family genetics. Oncologists and cancer centers are uniquely positioned to elevate the visibility of obesity as a cancer risk factor, yet many fail to do so even when patients are at clear and measurable risk. Weight management must be reframed not just as an adjunct therapy, but as an evidence-based component of cancer treatment and survivorship planning. Just as oncologists monitor blood counts, imaging results, and tumor markers, they should be tracking weight, metabolic health, and inflammation as ongoing indicators of risk and recovery. Lifestyle interventions, including supervised exercise, tailored nutrition plans, behavioral therapy, and when appropriate, pharmacologic or surgical options, must be made available to patients throughout the cancer care continuum. Importantly, this must be done without stigma. Too often, weight discussions are avoided for fear of offending patients, or they are conducted in ways that imply blame. But framing weight management as a clinical, evidence-driven strategy, just like chemotherapy or radiation, can help depersonalize the issue and empower patients with actionable steps. Studies consistently show that patients are open to weight-related guidance from trusted healthcare providers, especially when delivered with compassion and clarity. There is also an equity dimension that cannot be ignored. Obesity disproportionately affects marginalized populations, especially those with limited access to healthy food, safe places to exercise, or comprehensive health care. These same groups often face higher cancer mortality and lower survival rates. Failing to address obesity in oncology deepens this divide and perpetuates systemic health disparities. Integrating weight management into cancer care is not just good medicine. It is a moral imperative. The time for siloed care is over. Cancer is a disease of biology, but also of environment, behavior, and policy. Oncologists can no longer afford to treat tumors in isolation from the bodies and lives in which they develop. Weight management must be viewed not as a secondary concern, but as a central pillar of effective, modern oncology. This shift will require changes in medical education, interdisciplinary collaboration, expanded clinical guidelines, and better resource allocation. But the payoff could be enormous. Improved treatment responses, longer survival, reduced recurrence, and perhaps most critically, prevention of cancers before they even begin. The obesity epidemic and the cancer epidemic are now intersecting in deadly ways. If oncology continues to treat them as separate issues, the cost will be measured in human lives. It's time for oncologists to lead, not just in curing cancer, but in preventing it by confronting one of its most modifiable and urgent drivers.